college. Yeah, that's
I'm in town. Yeah.
Testing.
Thanks.
You can just set it up here.
the wraps usually. Yeah, do you like any special flavor? I'd like to welcome everyone to Pediatric Grand Rounds and the 2015 annual Jamie McNew Lectureship in Cytomegalovirus Research and Education. I want to take this moment to acknowledge the generous contribution of Ed and Louise McNew of Orange County, California. And here's their son, Jamie, a young gentleman in his early 40s now, with congenital CMV infection. This lectureship was established about 7 or 8 years ago. It's been a wonderful opportunity to bring in a lot of luminaries in cytomegalovirus research, and today is no exception. We're very fortunate to have Dr. Sallie Permar here from Duke University Medical School, Department of Pediatrics. Sallie is a native of North Carolina. She went to Davidson College, where she got her BS degree in biology, and then went to Harvard Medical School, where she obtained her MD degree, and then did a residency in pediatrics at Children's Hospital in Boston. She was an assistant professor of pediatrics at Harvard Medical School, and then about 4 years ago went back to North Carolina, where she became assistant professor of pediatrics, immunology, and molecular genetics. She was assistant professor for only 2 years and then was promoted to associate professor, and her work has been very distinguished, highly productive. Sallie has many honors and awards, including the SPR Young Investigator Award, conferred last year, the Distinguished Scientist Award from Duke University. She is a recipient of the National Institute of Health Directors' New Innovator Award, and she has now over 40 peer-reviewed publications, true translational, molecular immunology, and virology, supported by a variety of mechanisms, including a Doris Duke Scientist Development Award, several R grants from the NIH, and a grant from the Bill and Melinda Gates Foundation. Sallie has been very productive in both the arena of HIV transmission and cytomegalovirus immunobiology. And today she's going to focus on CMV, and her talk is titled Defining Protective Immunity Against Perinatal cytomegalovirus transmission. So with that, by way of introduction,
thank you, and thank you, Mark. I'm really honored to have been. Mark is someone whose work I have followed for a long time, and so it's very exciting for me to get to spend the whole day with him, and in and out of different herpes virologists' offices. That's also very exciting for me. It's also my first time to Minnesota, so I hear it's a sunny day, a warm, sunny day here. So I'm going to share with you some of the work that I've been doing in CMV over the last few years, really getting at this question of, can we define protective immune responses that we can then target through vaccination? And so just the requisite objectives that I'll talk about two things. One, talk about congenital cytomegalovirus transmission, talk about the epidemiology and the outcome of that infection, which you all may know already. And then ways that we're going about identifying maternal immune responses that may be protective. And then secondly, talk about postnatal CMV transmission, or transmission through breast milk, which is mainly a problem in preterm infants. So, and even of preterm infants, it's the smallest preterm infants that are most at risk, so the ones that you see in the NICU. So I'll talk about that and some work that we're doing in understanding that disease and then how we can prevent it. So starting with congenital CMV. So CMV, as you guys probably know, and what Mark and I deal with all the time, is that even though lots of people are pregnant in this world, not a lot of people know about this virus. And so I have been trying to promote, although in a very small effort, giving it a new name so that we can, catch the attention of people that need to know about this virus and the impact it can have on their infant. And so the birth defect virus, I think, is something that might make a splash and get pregnant women to listen about what they can do to protect themselves against this disease. So it is the leading infectious cause of birth defects and brain damage. It's in the herpes virus family. And the most severe outcomes are when the mom is infected primarily during pregnancy. So she remains seroimmune all through toddlerhood and through adolescenthood, and then can become infected the first time during pregnancy. And often it is exposure to toddlers that can be that primary exposure. But there's also transmission in the setting of either maternal reactivation of virus or reinfection with a new virus strain. And that can also lead to congenital transmission, but it's typically less severe, although some work has been done to show that you can still have hearing loss and other effects from that form of transmission. And the infant sequelae that we deal with in this infection is most commonly deafness, microcephaly or growth restriction, small head size and growth restriction, mental retardation, vision problems, seizure disorders, and even rarely death. So this is an important pediatric pathogen. So here's the disease burden. It actually impacts about 1% of all pregnancies, which is a staggering number of pregnancies. That is 40,000 in the US annually. About half of those are due to primary infection of the mom during pregnancy, and about half are from reactivation. And that's because our population, about half of women of childbearing age, are seropositive, and the other half being still at risk for a new infection during pregnancy. And that's different from developing countries where most people are seroimmune before childbearing age, and that's because of more group housing, less strict hygiene conditions. And actually, then this is really a problem of the developed world, or more of a problem of the developed world, which is not often how we think about infectious diseases. But of those 40,000 babies that are born with CMV each year, about 5,000 will go on to have a severe illness, and that's 5,000 annually. So they go on to have long-term disabilities. There are also hundreds of deaths per year. And the statistic that really gets me is that CMV is reported to be the cause of a quarter of infant hearing loss. And that is a staggering number to me. And what's really sticks out to me is that this is not a genetic cause. This is not something that we need gene therapy, that we need future types of therapies to prevent. We need a vaccine, and we know how to make vaccines. We just have to do the work to try to figure out what the immune response is that we need to be able to elicit. So I think we can do something about that, that hearing loss. But here's the epidemiology that you all may know already. So as I talked about, that there's about 30 to 50% of US mothers are at risk for a new infection during pregnancy. Of women that are previously infected with CMV, about 1% will go on to transmit the virus to her infant. Those can be associated with some long-term sequelae like hearing loss, but it's more often less severe than the primary infection of the mother. So of the women who are seronegative at the time of pregnancy, somewhere between 1% and 4% will go on to develop an acute infection during pregnancy. And often this can be some type of mucosal fluid exposure. Exposure to toddlers is a key one. So women in their second and third pregnancies, especially those that have kids in daycare, are more at risk. But also sexual contact during pregnancy is another main risk of transmission as well. So from those women who contract primary CMV during pregnancy, 40% will go on to transmit the virus to their infant. So that's a very high-risk group. And then of those, about a quarter have some sort of lasting sequelae of the infection. So there is an example of where a maternal vaccine has been extremely effective, and that is the Rubella vaccine. So the Rubella vaccine was not developed for the very mild febrile illness that it is. It was developed to prevent congenital rubella disease, which is essentially eliminated in this country and in countries where the Rubella vaccine has been used. And that's really demonstrated by this graph of showing that there was actually a Rubella outbreak in the late 60s, right before the introduction of the Rubella vaccine, which immediately plummeted the number of Rubella cases. The blue line is the number of congenital rubella syndrome cases, which was also peaking at the time that the vaccine was introduced because of that. The season before, there had been a lot of maternal infection. And so I work every day with Sam Katz, who is one of the original developers of the measles vaccine, and he was around for all of the Rubella vaccine that followed on the heels of the measles vaccine. And he said to me something once, which I will never forget. He said, in 1969 or 70, after the introduction of that Rubella vaccine, that there were schools of the blind and deaf that had to close because they didn't have enough students to fill them anymore. So that is what we can achieve with a cytomegalovirus vaccine, and that's what we're striving to do. So, but there's some important questions that are keeping us from developing an effective vaccine. So one thing just from what we learned from natural immunity is natural immunity has some protection against severe disease, because in women who are seroimmune, that it's pretty rare that even though they carry the virus in their body, it's latent. It's actually pretty rare that they're going to pass it to their infant. And when the infant becomes infected, it's a less severe form of the illness. So we have the idea that maternal immunity is somewhat protective. And there have been some trials of live attenuated vaccine and subunit glycoprotein vaccines, but have not yet reached a level of efficacy that led anyone to go on to develop that vaccine large scale. But what hasn't really been worked out is what are the maternal immune responses that of the natural immunity that are most protective against transmission or against disease. And if we could understand that, then we would know what to target with our vaccine. And instead of going straight to human trials with just trying the next vaccine that we were able to make, we would have some idea of how efficacious it would be prior to doing a very large phase 3 study. So some of the lessons that have been learned from the animal models, and Mark has been a leader in the animal models of congenital cytomegalovirus disease, especially in the guinea pig model. And we've learned a lot from that model. I think it's really shown that antibody responses can be protective. So if you just infuse hyperimmune globulin against one glycoprotein of the virus, that can protect in the guinea pig model. A GB vaccine can protect in the guinea pig model. And in another group, even a monoclonal antibody, a neutralizing monoclonal antibody was very effective in that model. So we have learned a lot that antibody responses are potentially, a very important target. But in human studies, they don't always work out as well as our animal models. So in the human studies, what has come out so far is while there's some initial excitement about hyperimmune gamma globulin, or Cytogam against CMV to treat women who have a recognized acute infection. While there was some initial data that was exciting, a randomized control trial done in Europe did not show efficacy. So there was some decrease in the group that got that hyperimmune globulin, but it was not significant. And another study is ongoing here in the US as well. GB subunit vaccine was used in postpartum women that had their first baby, those that were going to be at risk for getting CMV during their second pregnancy, since they already had a first child, who would be a toddler at that time. That vaccine was about 50% effective in reducing new maternal infections. So there was some hope there, but it didn't quite meet the mark on something that would be worth spending all the money on developing in large scale. So when I had a lot of experience in working in the non-human primate model of HIV, and actually my mentor in medical school developed the non-human primate model for HIV, or SIV, simian immunodeficiency virus. And so I got to learn the primate models. These are models that are used very frequently in vaccine development. Most recently, they've become famous for being used in the Ebola vaccine development. They're used in flu vaccine. They're used heavily in HIV vaccine. So, potentially a non-human primate model that is a step closer to humans is another preclinical test that can be used before we do a big phase 1, phase 2, phase 3 trial in humans. And although a lot of rhesus CMV or a lot of primate CMV viruses have been identified, what was not known is whether they were able to cross the placenta. And one of the best characterized viruses was the rhesus CMV virus. And it, again, all of these herpes viruses are so species specific that even the rhesus CMV is not exactly human CMV. It shares about 60% of its open reading frames with human CMV. So there's some still important differences, but this is maybe anatomically and immunologically a little bit closer to humans. But we had no idea if any of these primate viruses actually could lead to congenital infection, and that was probably because there's pretty much 100% seroimmunity in the populations of monkeys that we researchers study in all the primate centers. There's pretty much uniform CMV infection in infancy. And so having a highly seroimmune population, it's not easily recognized whether there's placental transmission. However, one researcher out on the West Coast, Peter Barry, had done a lot of work with infecting fetuses intrauterine, so actually injecting the fetus with the virus via an intrauterine injection, and found that injecting the fetus with a wild-type CMV virus could develop a disease similar to that in humans. So had brain lesions similar to that in humans, growth restrictions similar to that in humans. So it was known that at least the phenotype of the infection would be similar in that model. But so I set out to answer the question of whether rhesus CMV could cross the placenta, as that was sort of the barrier to using a non-human primate model. And what I knew already is that I wanted to stack the cards in my direction of being able to see it if it was there. And so we decided to immune suppress the mothers in order to be able to get higher virus loads, longer duration of viremia, and the best chance of actually seeing the transmission if it was going to happen. So this was our study design. So we wanted to, the monkeys have about a 6-month pregnancy. And so we split that up into 3 trimesters. And we wanted to get as close to the first trimester as possible because we know from human epidemiology that infection during first trimester is usually the most symptomatic disease. But we didn't want to go too early because there's been some issues with some of the interventions with monoclonal antibodies that have been done early in pregnancy in these models, maybe interrupting the initial stages of pregnancy. So we waited until 7 weeks of pregnancy, and we first used a monoclonal antibody to deplete the Cd4 T cells in one group of monkeys, and then we inoculated them with rhesus CMV 1 week later. Then we had, and we used 3 rhesus CMV variants. Again, I was stacking the cards in my favor for actually seeing the transmission. We used 2 wild-type strains and 1 more lab-adapted strain of rhesus CMV that were available from collaborators. And we inoculated at 8 weeks. We then had another group that was immune competent. We did not deplete them of the Cd4 T cells. And then we had a third group that was seroimmune pregnant mothers that were just treated with the Cd4 depleting antibody as a control to see what happened to their fetuses. So here was just showing that we were able to deplete the CD4 T cells in the group that we treated with the anti-CD4 depleting antibody, and that we, for almost 3 weeks, there were no circulating CD4 T cells detectable, but then they started to come back, but remained at a pretty low level during the rest of pregnancy. And this is the control group that there is actually some CD4 loss after infection, but did not, and this is just in proportion, did not reach the trough there. And I'm going to go to the next slide to show you the viremia that we were able to achieve in the moms. And what we used to look for congenital infection was amniocentesis, so similar to that what's used in humans to look for the congenital transmission. So this is our immune-competent mothers that I'm showing you first. So we had 3 pregnant moms. We got viremia in all of them, as expected, that peaked at about 2 weeks and lasted for about between 6 to 8 weeks. We found amniotic fluid virus, that's in blue, in 2 of those animals at about week 3 after infection. And in a 3rd animal, we did not find the virus in the amniotic fluid. And then contrasting that with the CD4 depleted monkeys. So we had a higher peak of viremia, so up to between 6 and 7 logs of virus, slightly longer duration of the viremia. And then we found amniotic fluid virus, shown in blue, in all of the monkeys. And then the other important thing was that in 3 out of 4 of the CD4 depleted monkeys, we had abortion, so fetal loss at about 3 weeks after the initial infection of the mother. Now, if you'll notice that we do have these crosses, that does mean a maternal death. So in one of the animals, there was actually an intussusception that may or may not have been associated with the CMV infection, but in a 4th animal, there was clear maternal disease caused by CMV infection with a myocarditis, actually, from CMV. So there was some maternal sequelae of the infection. The transmission was preceding the maternal death, but like in this case, they were somewhat close, and so potentially the fetal loss could have been due to the maternal health as opposed to the virus. But just to summarize what happened in this group, so in the CD4 T cell depleted group, we had 3 out of 4 spontaneous abortions at the time of peak maternal viremia. We detected CMV DNA in the amniotic fluid and fetal tissues. We had 1 live-born infant in that group, and I'll show you that infant was shown to be infected and had some sequelae of infection. And then in the immune-competent group, we had 2 out of 3 pregnancies that had infection in the amniotic fluid and confirmed in the infant. So this is our survival curve of only 1 infant, live-born infant from the CD4 depleted group. And just to tell you what happened in the control group, treating with just the CD4 depleting antibody, those pregnancies went through just fine. So there was no impact of that intervention. So then we wanted to just confirm that we did have placental transmission, and using immunohistochemistry, we were able to find the virus on both the maternal side of the placenta, in the decidua, as well as the fetal side, the villus trophoblasts. And then we were able to find virus in all of the tissues that were looked at in the placenta and the fetus from the aborted animals. One secret about the monkeys is you don't always get the products of conception because they will eat them if you don't get them quickly. So we got what we got. But then in the live-born infant in that group, there were some notable sequelae. One, a liver lesion, a calcification that was noted in that infant on fetal ultrasound, as well as some persistent neutropenia in that animal. So here shown in red with the dotted line being the median for infant monkeys. So there was prolonged neutropenia in the 1 live-born infant in the CD4 depleted group. However, we really didn't see an impact on fetal growth. So this is measuring by fetal ultrasound, the femur length and the biparietal diameter, the black line being the norm. So all of our animals, either CD4 depleted or not, had normal fetal growth. But then we looked at the rest of the live-born infants to assess whether they actually, to confirm infection. And in the initial live-born infant from the CD4 depleted group, we had some of the highest viral loads in saliva detected. In the immune-competent group, we had virus detected in saliva in 2 of the monkeys, and 1 of the monkeys also in urine. One thing about saliva that's tricky is that could be contaminated by maternal breast milk. So we did look at breast milk virus loads there as well. And in the one animal that had some saliva virus that also had amniotic fluid virus, the breast milk virus load was not quite as high as the other. So we think maybe that was a true finding. However, just as a control, we did the Cd4 depleted group. And here, interestingly, so this is a group that you may think about secondary infection. So we've taken a group of monkeys that had CMV already and Cd4 depleted them, and then we wanted to see, did we see any congenital transmission? We didn't find any virus in the amniotic fluid, but at least one animal we found virus in the urine, which should be a sterile site. So potentially, and this needs more work, could work on a model of secondary infection in this model as well. We did a little bit of molecular virology work to try to figure out what were the viral determinants, since we infected with 3 different strains of rhesus CMV, we want to know which one was actually crossing into the placenta. And what we found is that one of the wild-type viruses here, shown in red, accounted for either 100% or 90% of the viruses in plasma, and then accounted for all of the viruses that were detected in amniotic fluid. And we did this by single genome amplification, looking at a region that was different between all 3 of the viruses that we used. So we think that maybe a wild-type virus is needed to cross the placenta, but more work will need to be done with other mutant viruses to try to figure out the viral determinants of that transmission. So we had this model where we saw more severe disease in the immune-compromised Cd4 depleted group. However, if you remember your immunology, the CD4 T cells, the helper cells, are actually going to impact 2 arms of the immunity, right? They're going to impact the B cell immunity, or the humoral immunity, because of the T cell help that they give to the B cell response. But then they're also going to impact the cellular immune response. So the IL-2 that's secreted, the CD4s can act as antigen-presenting cells. So you're really impacting both arms of the virus. So we did a little more work to try to figure out which pieces of those immune responses were most impacted by the CD4 T cell depletion. So we could try to get at what are these maternal immune determinants that determine whether you have a severe outcome of fetal loss, or whether you get CMV but you don't care, you grow up to be a normal monkey. So first looking at the B cell responses. So we first just looked at the binding IgM and IgG responses to the whole virus. And the blue is the immune competent animals, and the red is the CD4 depleted. And we saw slightly higher IgM response actually in the CD4 T cell depleted, kind of unexpected, but similar kinetics of the antibody response. And the IgG responses, the kinetics were pretty similar, maybe slightly earlier in the immune competent animals compared to the depleted, but pretty similar, not a lot of difference in the kinetics or the magnitude of those binding antibody responses. So then we looked at avidity. Avidity has previously been shown to be important in protecting the mother or protecting against congenital transmission. So we tried to look at whether the avidity was impacted by the lack of CD4 T cell help. And we didn't see major differences in avidity at these early time points of the IgG response. So the strength of the binding to the virus seemed to be similar between the 2 groups, whereas it was different from chronic infection, which you would expect the higher avidity. However, then when we started to look closer at the glycoprotein-specific response, we were able to detect some differences. So here we looked at glycoprotein responses against pieces of the virus that are important to virus neutralization. So we looked at the rhesus GB, the GHGL, and the pentameric complex. All of those are different complexes of proteins that are on the surface of the virus and are important for neutralizing the virus. And what we started to see is that in the blue lines, the immune-competent animals typically had earlier responses against these neutralizing domains compared to the depleted animals. And so then maybe not surprisingly, when we looked at the actual neutralizing response, here done 2 ways, both looking at the neutralizing response in epithelial cells and neutralizing responses in fibroblasts, we saw considerable differences in the kinetics of the development of the response. With the blue animals being the immune competent, developing a more robust response earlier that neutralizes the virus compared to the red, the CD4 depleted. And importantly, this time period between 2 and 3 weeks is when the transmission was actually happening. And so that was a critical window where potentially not having virus neutralization was a piece that led to the more severe disease. But then we want to look at the other side of the equation, and that's the T cell responses. So we looked using intracellular cytokine staining. So here you stimulate the T cells with linear peptides against different pieces of the virus, and looked at their ability to generate cytokines against the response. And when we looked at CD8 T cell responses against two key proteins that for the cellular immune response, which is PP65 and IE1, or the immediate early 1. We didn't see major differences in the PP65 CD8 T cell response, but what we did notice is that there was really a lack of T cell responses against the IE1, that we hardly saw any CD8 T cell responses in the Cd4 depleted group, whereas in the immune competent group, we started to see some of these low-level T cell responses at that important time point of 3 weeks after infection. And actually, what I'm circling is the TNF alpha response actually was significantly different between the two groups. So in summary, in this model, we found that the rhesus CMV can be placentally transferred and can provide a relevant large animal model. And it can be used to define the critical immune responses that are needed to prevent transmission or prevent severe disease, and also potentially vaccine candidate testing, which remains the future phases of the work. CD4 T cell depletion did lead to a higher rate of fetal loss, and the CD4 T cell depletion also impacted the neutralizing antibody response and the TNF alpha secreting CD8 T cells. And so, potentially targeting those immune responses will be an important piece of a vaccine. But our work is not done. So the few questions that we have that we want to apply in this model now is, number one, can passive antibody infusion of CD4 T cell depleted monkeys, can that prevent against the severe disease or prevent transmission altogether? So we're doing that study right now as we speak. I check with the vets every day. How are the fetuses? But then some other potential questions that we're trying to answer is, what was the repertoire of the B cells in those animals that did not transmit the virus versus the ones that did? And so we're actually isolating the plasmablasts from the rhesus blood, the early B cell response, and making the monoclonal antibodies that are being produced by those B cells that are stimulated by the CMV infection to look at really what was the early response that was protective against the severe disease in the immune competent monkeys. And then we want to do another study to deplete CD8 T cells and to see what the impact is there on the fetal disease. So I'm going to turn now to the epidemiology of postnatal CMV transmission, and also talk a little bit about some new things that we've learned on the impact of that on our preterm infants. Hopefully some of you from the NICU are sitting out there, since this is most relevant to you. So we know that another form of CMV transmission besides placental transmission is breast milk transmission. And it's actually probably when you're supposed to get your CMV. That's how the humans and herpes viruses evolved, that these viruses are shed in mucosal fluids. You're supposed to get it during breastfeeding. But it's typically asymptomatic in term infants. So it's not a problem if you get your CMV via breastfeeding if you're a term infant. However, in very low birth weight, preterm infants, they can develop a severe disease or a sepsis-like disease with postnatal CMV acquisition. And unfortunately, this is the population that we know now benefits the most from maternal breast milk feeding. So maternal breast milk feeding is protective against necrotizing enterocolitis and protective against sepsis, bacterial sepsis. And so we are now pushing breast milk like we haven't done before in NICUs because we've learned so much about how protective breast milk is. And it's not even donor milk or pasteurized milk that gets you the same effect. It has to be mother's milk that does not have to be pasteurized to get the most benefit. However, we haven't really understood whether we need to do something about those few infants who get CMV from the maternal breast milk exposure. We've got these two clinical conundrums that are polar opposites of each other, that we're pushing breast milk, yet we're leaving infants at more risk of CMV, yet they're getting benefit for these other things. But what we didn't know is CMV causing long-term outcomes in these kids? Is it impacting their long-term health so that we need to do something about that? And I think that was the missing piece. And for me, trying to understand, I study a lot of breast milk in relation to HIV, which we know it's a problem for getting HIV via breast milk. What I didn't know is it a problem if a preterm infant gets CMV from breast milk? And so I wanted to try to understand that question before I start working on immune protection against that version of transmission. So interestingly, about 40 to 50% of CMV-exposed infants will become infected via breast milk exposure, so it's pretty common. And that is despite over 90% of women shedding virus in the breast milk. So if you're in the NICU and someone is considering CMV transmission and they ask you, should we test the mother's breast milk? Say no, because it will always be positive. If the mom is CMV seropositive, what you could do is check if the mom is CMV seropositive, but checking the breast milk is not going to be beneficial. What's also known about breast milk is there are CMV-specific immune responses. So there are CMV-specific CD8 T cells, CD4 T cells. There are also antibody in breast milk that's specific for CMV. There has been some work that CMV transmission via breast milk is more likely when there's higher viral loads, and when you can culture the virus. So there does seem to be some effect of the magnitude of the amount of virus being shed that is consistent with risk of transmission. And one other thing that we know, and as virologists, I don't think this is surprising, that if you freeze the virus, you can reduce the titer, and therefore if you freeze the breast milk where the virus is, you can reduce the titer and therefore lower the risk, but you don't take it away. And I think we know that as virologists, we put our viruses in the freezer all the time and get them back out to use them. So freeze-thaw of breast milk can maybe reduce the risk, but it's not going to take it away. So some important questions in postnatal CMV transmission is, what is the long-term outcome of symptomatic kids that actually have disease from the postnatal CMV acquisition? What is their long-term outcome? And then what are maternal immunologic or virologic correlates of protection against breast milk transmission? Because if we knew that, then we could maybe screen breast milk to determine the risk, or even look towards doing some immunologic intervention in the moms to prevent transmission. So I guess I was a fellow or early assistant professor. A resident came to me and was interested in this question, so we banded together. Sarah Meyer was her name. She's now an EIS fellow at the CDC. But we went through a retrospective study from one NICU, the Brigham and Women's NICU in Boston, and looked at all the cases of CMV that had been diagnosed in the past. We included about 12 years. And tried to piece out which were postnatal and which were congenital as a first step. And what we did is we took the age at which the infants were diagnosed. So if they were greater than 21 days, we thought that was likely postnatal. But we also eliminated any kids that had any findings that were potentially consistent with congenital infection, like microcephaly or any head ultrasound calcifications, things like that. So we tried to narrow down which were the postnatal and the congenital by that route. And what we got is pretty consistent with who we know to be impacted by postnatal CMV transmission. So it's the very lowest birth weight infants. So the median birth weight was 688 grams, very different from congenital. The birth weight, the gestational age was very low, 26 weeks as a median. The day of life of diagnosis could be very far out from birth, so up to 50 days. And the exposure risk was right. So all of those ones that we defined as postnatal were breastfed. And so we first looked at, well, what symptoms did the babies have that led someone to test for CMV? And the ones that are highlighted in yellow were most striking. Pneumonitis was extremely common, and we defined that by either new X-ray findings or going backwards in your respiratory needs. KUB findings were fairly common, but not different than the congenital. We compared this within 14 days of the original diagnosis. The skin findings were, not surprisingly, more common in congenital CMV, which can be associated with a blueberry muffin rash, so that seemed consistent. And retinitis was more common in the congenital infection, which is also consistent. And the hepatosplenomegaly and failing your bears was not different between the two groups. And then we looked at new laboratory abnormalities, CMV being associated with thrombocytopenia and hepatitis. And here, the new diagnosis of hepatitis was more common in the postnatal group than in the congenital group. The congenital group can have a hepatitis as well, but this was something that was newly recognized in the postnatal infected group at the time of the diagnosis. But here was the thing that, that struck us the most. So then we tried to look at the comorbidities or actually the outcome of the postnatally infected group compared to the congenitally infected group. And, this is actually a comparison of the postnatally infected group to a database that is collected within the NICU at Brigham and Women's and many other NICUs throughout the country called the Vermont-Oxford Network Database, or the VAUGN database. And it was basically set up to make sure that all NICUs had the same level of comorbidities so that, you know, one practice doesn't seem to stand out above another for being better or worse at generating these outcomes. So we looked at our postnatally infected group. We weight and gestationally age matched them to this VON database of these four big outcome predictors. And what was really striking is that while sepsis, necrotizing enterocolitis, and intraventricular hemorrhage were similar between the groups, the bronchopulmonary dysplasia was significantly more frequent in the postnatally infected group. 80% were on oxygen at 36 weeks of age compared to their age and weight matched group of infants from the same NICU. So, and this is one of the things that we tried to look at, any long-term outcome that could be picked up in developmental clinic or any follow-up that these children were seeing specialists in follow-up. We had a lower number of these children that had records at follow-up, but we did not see increased risk of hearing in the postnatally infected group here. It was common in the congenital group, which would be expected. But that BPD finding was really striking, and so we wanted to study it further. So when I got down to Duke, there's a group at Duke who works with the Pediatrics research group, or that's a NICU group, that oversees 384 NICUs throughout the country. They put together, they were sort of a leader in the EMR back in the day, and they have excellent database of all of the infants going through these 384 NICUs, or 348, sorry. And so the group at Duke works with that group to do statistical analyses that are very highly powered. And so I just asked them, well, do you guys have CMV data? And they said, oh, I don't know, we just look at bacteria. And they looked through and they said, oh yeah, actually we do have some CMV data. So I said, let's do the study. So we looked at using that group. We again tried to define those that were postnatally infected. And there we used the day of life 21, had to be diagnosed with CMV at greater than 21 days of life. And here we also used an ICD-9 code for CMV that was newly entered after 21 days of life as well, in case the virologic testing was missed in the database. We tried to exclude children that may have congenital infection. We excluded children with a CMV diagnosis or any virologic testing prior to day 21, and any clinical diagnoses that would be common in congenital infection, like microcephaly or intracranial calcifications. And then we used a statistical technique called propensity score matching, which actually allows you to take a infant that's extremely similar to the case infant, the CMV-infected case infant that you're studying. So we matched on as many things as we could think of because we had the ability to, because we had so many infants in the study. So we matched on things like cardiorespiratory support, the NICU where they were, obviously the gestational age, the birth weight, so all the common things you can think of, but we were able to go really deep, like how many pressors you were on at 3 weeks of life, because we had such a huge group to work with. What we specifically powered for was to look at the difference in the postnatal CMV-infected group and the non-infected group in the death or BPD rate at 36 weeks of life using Poisson regression. This work was done by a current ID fellow at Duke, Matt Kelly. And so here is what we used. So we had over 100,000 infants that we were able to look at statistics on. Of those 100,000 infants, 328 were diagnosed with CMV that could have been postnatal CMV. About half were based on a diagnosis and virologic testing. About a third were the diagnosis only, and another quarter were just the virologic testing. And then we used that propensity score matching to match to 303 of our case infants were matched to very well to a control. So we threw out the infants that we couldn't match very well. And we ended up with 606 infants. The median gestational age was and birth weight were both, again, very low, which is of the cases, which is expected, 25 weeks and 725 grams. And then just as a check, almost 90% of the infants with postnatal CMV had a change in their cardiorespiratory status or a laboratory abnormality at the time of their CMV diagnosis, so that consistent with a symptomatic postnatal CMV acquisition. And here's the results. So we found that the kids who had postnatal CMV infection compared to their very well-matched group of infants did have a higher risk of BPD or death when we looked at that. And then when we broke out BPD alone, that accounted for all of the difference in the group. So the infants with postnatal CMV were about a third more likely to have BPD compared to their very well-matched control infants. And so this to me then now gives me a new motivation for we do need to do something about postnatal CMV acquisition in the NICU. And so I have new resolution to work on that problem. And so basically here that we found the potential impact, long-term impact of bronchopulmonary dysplasia or chronic lung disease that needs our attention. And then I'm just going to go through this quickly because I'm out of time, but actually a technician in my laboratory did this work. She's actually a medical student at the University of Minnesota today. I don't think she was able to come to the talk. But she did some work on looking at whether we could look at differences in maternal breast milk from those women who transmitted the virus to their infant, to their preterm infant, and that infant had symptomatic disease, versus women who were breastfeeding their preterm infant, and that infant did not have symptomatic disease. So we tried to ask a question if we could see any particular differences in the maternal immune responses. So this was a very small study because this is a pretty rare diagnosis. We only had 5 symptomatically infected infants when we were monitoring 3 different NICUs over, I think, a year and a half. But we had 25 mothers who were breastfeeding their infant, were seropositive and did not transmit or didn't have a symptomatic infection. Again, we had the bronchopulmonary dysplasia finding, just to show you that was consistent across the groups. Here's the maternal CMV virus load in breast milk. It was not notably different in the transmitters, and notably several of the transmitters had virus load that was about at the level of our detection. So virus load in this study did not seem to be a major determination of whether you're going to have symptomatic disease from postnatal acquisition. We looked at the T-cell immunity in breast milk and blood of the women who transmitted versus did not transmit. Did not seem to be significantly different between the non-transmitters to the non-transmitters. When we looked at the antibody responses, there was some suggestion that maybe the non-transmitting mothers in plasma had a better IgG response, but the avidity and the neutralizing response was similar between the groups. And then we had one suggestion from looking at correlations with breast milk virus load that this time the breast milk IgG avidity was inversely associated with virus load, potentially looking at some local impact of local immunity on control of viremia. So we did not find major differences in virus load or CMV-specific immune response in mother's milk of transmitting versus non-transmitting mothers. So screening milk may not be something that we can pursue to try to determine the risk for each infant. But maybe there were some hints that if we could enhance the maternal IgG response, that we would do some good with reducing the transmission. But that remains to be shown. So I'm going to stop there and just a lot of acknowledgments because a lot of people's work went into this. At Harvard, a lot of the postnatal CMV work was done with Sarah Meyer, who was the resident, Karen Popolo, who's the NICU doctor, and Liz Ellinger is the now University of Minnesota student, so look out for her. Matt Kelly at Duke University, who did the large pediatrics database study. And then for the rhesus CMV work, my postdoc, Christy Ballas, led this work beautifully, and she is to thank for a lot of that work. My collaborators are Mitty Cower and Peter Berry and Don Diamond for that work as well. And I'll take questions.
Thanks so much, Sally. I'll take the liberty of asking the first question. I'm thinking back to those landmark studies of Ann Yeager and colleagues at Stanford in the 70s. Of course, CMV was acquired by blood transfusions commonly then. It was pre-surfactant, so there was a lot of hyaline membrane disease. It seems to me those papers showed an association between postnatal CMV acquisition, usually by transfusion, and worsening of lung disease. Am I remembering that correctly?
Yes, you're right. Yes. I won't be the first person to show that, but I think, yeah, the major difference being the postnatal infection, we didn't know.
So what do you think mechanistically is going on here? In your findings, is it pneumonia, or is it intraparenchymal infection with the virus, or what do you think?
Right, I mean, there's two major possibilities. One is we know CMV causes a pneumonitis, and so it could be a direct viral effect that's leading to the risk of chronic lung disease, but there's also the possibility that because of that pneumonitis, you need more respiratory support acutely during your infection and maybe even long term, and that is one of the risk factors for chronic lung disease, is being on respiratory support for longer. So I think either a combination of those or one of the two of those is going on.
Other questions?
Yeah, that's right. Well, I would love to be able to answer it, but yeah, so there is an oral drug for that can treat cytomegalovirus pretty well, which is Valganciclovir, and it's actually revolutionized the treatment for congenital CMV, which I didn't talk about, but there is now work showing that oral Valganciclovir can prevent some of the developmental delay and hearing loss in congenitally infected infants. So one maybe next question would be, should we be treating postnatal CMV acquisition in young preterm infants to prevent BPD? And I don't know the answer to that. I think that it is going to be problematic to study because it's such a rare disease. We had to use 100,000 infants to find 300, and so studying that in a phase 3 trial is going to be really difficult. However, the antiviral study collaborative cohort that David Kimberlin runs at UAB, they are studying PK at least in infants, so at least we will know what dose, and studying it in preterm infants. So at least we will know what dose. But I don't know if I even see the phase 3 trial going on in that study. It was, so we did what we could from the fetal tissue. We let these infants go to term, and then we followed them up for 6 months, actually, and now we're doing more, harvesting the fetus, so I think we'll be able to do this more better. But there was definitely virus in the brain, liver, spleen, gut, so really anywhere that we had tissue to look in the fetuses, we found it by DNA. We couldn't do immunohistochemistry on a lot of them because they had autolysis, because they had aborted and were still in the womb for a few days. So, but an important piece is, do you have virus in the brain? And we did find it there.
Another question, Dr. Mansky?
Well, I think that we're still learning that. I don't think that I can even fully answer that question, but I think that maybe we'll be in a zone that we can potentially see the direct correlation to humans because of the length of pregnancy, the anatomic space, the immunologic factors, so all of those being closer to humans. Of course, it's obscenely expensive, so that's the major downside, to get these herpes-free virus animals, to get them pregnant, to do this work, and that's why you see our groups of 3 and 4 animals. So we can't do a guinea pig study where you can use a good N number to actually get good p-values, so I think there's a role really for both, that potentially some screening modalities that then, when things look promising, can go to the primate level and then to the human level. But I think it's really going to be a tiered approach. One problem, of course, is that all of these are species-specific viruses. So you can't take a vaccine and test it in guinea pigs and then test it in rhesus and then humans. They all require, changing it to the system that you're working in. So what I would love to do, and I know Mark's already tried this, and so he'll probably tell me why it won't work, is to humanize the rhesus virus, at least for those parts that we think are important, like GB or like the pentameric complex, so that we can study human vaccines in the setting. But I just don't know yet if we're going to be able to do that, and I don't even know if we're going to have a good model in immune-competent monkeys, which is also really important for the vaccine testing. So I think there's going to be a role for both for a long time to come. Oh, sorry. They're waiting for the mic.
Is there any difference in postnatal steroid use between the unaffecteds and the postnatally acquired? I know your numbers were small.
I'm sorry.
Postnatal steroid use?
Steroid use, okay. I don't think that we looked at that, and I don't think it was something that we matched on, actually. I'll have to go back and look at all the things that we did the propensity score matching on. But that's a good point to, I will look at that, but I don't know.
Other questions? If not, thanks again, Dr. Permar, for a terrific talk.
Thank you.
That's great. That's great. It's just perfect.